Today we are going to start about antidepressant drugs. Most drugs potentiate either directly or indirectly the action of norepinephrine and serotonin in the brain to enhance or diminish the depressant behavior. Now, the depression is due to the deficiency of monoamines such as norepinephrine and serotonin. These two are the main key sites. Now, these are the drugs. So first, we will study about selective serotonin reuptake inhibitors, SSRIs, citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. Next is SNRIs. This is SSRIs. They selectively inhibit only serotonin. These are serotonin and norepinephrine both reuptake inhibitors. Desvenlafaxine, duloxetine, levomil, nacipran, venlafaxine. Third is atypical antidepressant. Bupropion, mirtazapine, nefazodone, trazodone, vilazodone, vortizapine. Then TCA, tricyclic antidepressants due to their structure. Amitriptyline, amoxapine, clomipramine, desipramine, doxepine, imipramine, meprotilene, nortriptyline, protriptyline, trimipramine. Then monoamine oxidase inhibitors, isocarboxacid, phenelzine, selegiline, prenylcypromine, and drugs used to treat mania and bipolar disorder. They are carbazepine, lamotrigine, lithium, and valproic acid. These were the list of the drugs. Now first we will see SSRIs, selective serotonin reuptake inhibitor. These act selectively on serotonin reuptake. They inhibit serotonin reuptake having 3000 to 303,000 fold greater selectivity for serotonin transporter. That's why they are called SSRIs. Whereas SNRIs, they non-selectively, they inhibit the reuptake of both norepinephrine and serotonin. Now drugs. Uptake inhibition, selective serotonin reuptake inhibitors, SSRI, fluoxetine. They will not inhibit or act on norepinephrine, they will selectively inhibit serotonin. SNRIs, serotonin norepinephrine reuptake, venlafaxine and duloxetine, they will inhibit norepinephrine as well as serotonin. TCA, imipramine and nortriptyline, they will have both activity but more towards norepinephrine and little less towards serotonin. Now actions. SSRI, they will block the reuptake of serotonin, which will lead to increase in the concentration in synaptic cleft. Now antidepressant including SSRIs, they typically last 2 weeks to produce. They need at least 2 weeks to produce significant improvement in mood and maximum 12 weeks. Onset of action is 2 to 12 weeks, so you cannot just start and see progression of the symptoms, but it requires 2 to 12 weeks. When you administer, the patient will have depression. After 2 weeks you have to check about its symptoms. 2 to 12 weeks is the onset of action. Therapeutic uses, psychiatric disorders such as obsessive compulsive disorder, panic disorder, generalized anxiety disorder, post-traumatic stress disorder, social anxiety, premenstrual dysphoric disorder, bulimia nervosa. Pharmacokinetics, peak levels 2 to 8 hours. Food has little effect, so they can take it with food. Half-life 16 to 36 hours. Metabolism is by cytochrome P450, so they will be affected by enzyme inhibitor or inducer. Fluoxetine differs from the other members as it have greater half-life of 50 hours and its active metabolite is quite active for long days. Fluoxetine and paroxetine are potent inhibitors of CYP450. Isoenzyme CYP2D6. Other isoenzymes are involved with SSRI metabolism, may also be inhibited to various degrees by SSRIs. Adverse effects: headache, sweating, anxiety, agitation, hyponatremia, nausea, vomiting, diarrhea, weakness, fatigue, sexual dysfunction, insomnia, and somnolence. You can see here nausea, anxiety, drowsiness, insomnia, sexual dysfunction, and drug interaction due to their inhibitory effect. Now, discontinuation syndrome. It will have withdrawal syndrome. Fluoxetine has lowest risk due to its longer half-life. Possible signs will increase headache, malaise, flu-like symptoms, agitation, irritability, and change in sleep pattern.